we're going to go over my updated version of bugs, drugs, and stem cells. It's a nice introduction to the infectious disease perspective for transplant ID with the added benefit of the BMT perspective. So I have no disclosures except that we're going to be talking about obviously bugs. So because this was originally presented at a national meeting, I had integrated 3 quick pre-test questions. One is a hematopoietic stem cell recipient patient at risk for community-acquired respiratory infections. Pre-test question number 2 is what is the empiric drug of choice for neutropenic fever in a patient who has a history of an ESBO-bacteremia with his prior chemo. Number 3 is which anti-therapy is contraindicated with short QT syndrome. So goals and objectives, we're going to go over an introduction to stem cell transplant from an ID perspective. Obviously this will be briefer than what would be needed for a BMT fellow, but adequate for those of us who are transplant ID. Antimicrobial drugs, timeline for infections, tools for workup of infection, current paradigm for neutropenic fever, treatment of quote-unquote common infectious diseases, and ID resources. So, whenever somebody is told that they need an allogeneic transplant, as you can see that at the top of the transplant is required. So we first look at their family members because there are multiple factors that overall the patient does better if we can get a closer match from the family. So we'll look at match-related donors, first-degree members, mismatch-related donors, and then haploidentical. So haploidentical are also mismatched, but it's a different style of chemotherapy, for lack of a better word. If there are no family members or just no matches in the family, we look at national registries. We first look at U.S. registries because we are in the U.S., and then we look at international registries. So that would be a match unrelated donor or mismatch unrelated donor. And then for the centers that also do cords, if you don't actually match to someone who's an adult and alive, then we look at the cord registry due to multiple issues and a lot related to cell count. For adults, we traditionally need a double cord, but understand only one of the cords will actually engraft, donor A or donor B. And then for these ones, because there's such a high innate risk of lack of engraftment, they actually, at the same time that they pick their first 2 options, they'll pick up their backup options traditionally. So allogenic recipients, mortality and morbidity, there are early causes and late causes, and you can see there's a variety of different issues, whether it's disease relapse, which honestly, if you have early relapse, it's very bad. Acute or hyperacute GVHD, for example, GI having diarrhea of 6 liters is not sustainable. Having your skin slough off like with Nikolsky sign is also not sustainable. Regimen toxicities in terms of long-term causes, multiple issues, but more importantly, the point is to show that infection is on both of these lists. How does immunosuppression work? Well, in general, like you have 3 mechanisms going on concomitantly. You're trying to deplete the lymphocytes, you divert them, or you block them. And so then that's what is happening. Then what about the actual drugs? There's the therapeutic effect, meaning you're going to have suppression of graft versus host disease. But you're also going to have undesirables, which are like infections or secondary cancers. And then there's actually non-immune toxicity, like calcineurin inhibitors and nephrotoxicity, though this is more of an issue in organ transplant because when you're on immunosuppression, you're on it for life, whereas traditionally in bone marrow transplant, the goal is you only need it for a year or 2, and then you get off of immunosuppression if you're not in like the grips of graft versus host disease. This is Dr. Halloran's paper that still is a landmark graphic about showing where these different drugs work. For example, you have the calcineurin pathway along the left side leading to NFAT production. You have then towards the middle right where the mTOR, you have the JAK3 pathway going to mTOR going into the nucleus, so that mTOR inhibitors affect there. Nucleotide synthesis also affected. This graphic is from the same paper, just showing like these are your pathways and now these are your drugs on top, understanding that on the far right MPA, this is for where MMF is having the effect. So talk about drugs again from a different perspective. Calcineurin inhibitors, you have tacrolimus and the older cyclosporin. Your adverse effect pertinent to us is acute or chronic kidney dysfunction. mTOR inhibitors, it's all about poor wound healing, whether you're an organ transplant or bone marrow transplant, definitely poor wound healing. Where I trained, for example, we use sirolimus in our Hep C liver transplant patients because of the antiviral effect, but we couldn't start the sirolimus until the superficial wound component had actually healed, otherwise the risk of dehiscence was too large or too high. Purine biosynthesis inhibitors, this is your MMF. Corticosteroids, you comes also in more flavors than I thought there were. Systemic, non-absorbables like the budesonide, which we often use for kind of lower level GVHD of the gut, and topicals. In terms of drugs that are also used to augment the immunosuppression, we have B-cell depleting like rituximab, T-cell depleting ATG and alemtuzumab, but the goals, they could be different. So like when a bone marrow transplant doctor looks at rituximab, they're like, oh, I have 6 months worth of graft versus host disease activity, and I look at rituximab, I'm like, well, I have 1 year worth of problems before I'm able to replete my B cells to get, say, if I wanted to give a vaccine and have a vaccine response. In Transplant ID, we love this type of graphic. The net state of immunosuppression. On the left side, you have all the different drugs that help immunosuppress a patient. Steroids, calcineurin inhibitors, mTOR inhibitors. But on the right, you have all these infections, from semi-normal ones all the way up to high-end ones like EBV and post-transplant lymphoproliferative disease. There have been cases where the patient is so immunosuppressed that despite giving lots of directed drug, for example, against CMV, the patient still dies because of the infection, because we cannot overwhelm the system. The body is not helping at all to clear the CMV infection, and the patient dies, not because of resistance, but simply because the patient's too immunosuppressed to survive. And then of course secondary cancers are also on the right hand side, that the inability to control after the first error, so then you get like skin cancers, a lot of non-melanomatous skin cancers definitely seen in all sorts of transplant recipients. So we went over the introduction. Now let's talk about drugs, antimicrobial drugs. So antibiotics, antivirals, antifungals, we're going to touch upon all of them. In terms of antibiotics, we have my favorite fluoroquinolone, Cipro, Levo, Moxi. You can see Moxi, of course, is the only one with anaerobic coverage. Atypical coverage increases towards the Moxi, but Cipro by far has the most Pseudomonas coverage. And then what is also concerning in neutropenic patients is the risk for strep viridans, and Levo has more than Cipro. Technically, where I work, we do not have Moxi on formulary. We tend to be a Cipro or Levo type of facility. Ceftonir we use also oftentimes for prophylaxis when patients' QTC is too elevated for the safe use of fluoroquinolones or an allergy. The issue is understand that like in neutropenia, you need prophylaxis against Pseudomonas, but ceftonir has zero coverage. So you can't even say, my patient was on ceftonir, now I have Pseudomonas sepsis that they broke through, because it simply does not have coverage. Pneumocystis prophylaxis, this is also something every patient that goes through an allo transplant that we have to think about. Bactrim covers not just pneumocystis but toxo, dapsone only only for Pneumocystis, atovaquone for both, inhaled pentamidine only for Pneumocystis. So there's a couple caveats with this slide. The dapsone, you have to order your G6PD before ideally you use the dapsone. Inhaled pentam can cause bronchospasm, so I'm not a big fan of using it, for example, in patients that have asthma or just had a respiratory infection, or if they have a VQ mismatch because they have pneumonia. Using inhaled pentamidine is not then your drug of choice, even if they are toxo-negative. Talking about IV antibiotics, cefepime, piptazo, and meropenem, this is a very important concept to understand. So especially for neutropenic fever, when you look at I need Pseudomonas coverage, so that's why we look at these three drugs as options. You have to be like, okay, is my patient having abdominal complaints? So then I need anaerobic coverage. So piptazo and meropenem innately have anaerobic coverage. So then you're like, okay, well, do I have ESBL problems? If I don't have ESBL problems, then Zosyn is my drug of choice, or piptazo. If I have enterococcus, you can see piptazo has the best enterococcus coverage. If I have no belly problems, no enterococcus problems, then cefepime is then my more narrow drug and the drug of choice. If I have a history of ESBL, as Dr. Tony here at USFOB says, had it once, got it again, you're definitely at risk, and then meropenem is your drug of choice. Antivirals. So considering people who know me well, they understand I think in pyramids, and it's all about hierarchy. So, you have acyclovir, you have the two pro drugs, HSV and VZV coverage. Above that, you're going to add then to ganciclovir, the pro drug being Valcyte, not to be confused with Valtrex. This covers HSV, VZV, CMV, and HHV6. Above that is foscarnet. So now you have HSV, VZV, CMV for my program, for example. If the patient is still neutropenic, you don't want to use ganciclovir because that's the main thing is bone marrow suppression. So for us, we'll use foscarnet. And then, but it'll be slightly different, for example, an organ transplant because, those kidneys, they're being pounded by calcineurin inhibitors for life, that we often use more ganciclovir because their bone marrow should be pristine. So they can handle the ganciclovir, but they're not going to handle the foscarnet. Up on top, you have cidofovir, HSV, VZV, CMV, adenovirus, and BK. Understand though cidofovir, there's a lot of issues with nephrotoxicity, and actually as you go up this pyramid, traditionally not just nephrotoxicity increases but also cost. In Canada, for example, to get cidofovir, you have to call literally the national helpline to get a single dose of cidofovir. Antiviral drugs, talk about anti-CMV drugs, you have the three ganciclovir, foscarnet, and cidofovir. The key thing here is that it's affecting, they're all going through the CMV DNA polymerase. But whereas ganciclovir and cidofovir are both competitive inhibitors, foscarnet, it reversibly and non-competitively inhibits activity of the CMV DNA polymerase. This will become important later on when we talk about resistance issues. Antifungals. So this is my own graphic. I apologize, it's very basic. You have the cell wall, cell membrane, nucleus, my pseudomitochondria, and I suspect the endoplasmic reticulum. There are definitely controversies in the use of combination antifungals, where again there are differences of thought in the literature and in the different places that I trained of. The one that made the most sense to me is you should not use two drugs or two different classes where one is depleting the source of the other. So for example, consider maybe something against the cell wall and something against the cell membrane. Do not, for example, utilize two anti-cell membrane drugs. Again, this is very controversial, but at least we should all understand where these drugs work so we can try to optimize them as best as possible. So echinocandins like micafungin, caspo, and indulafungin, they're against the glucan in the cell wall of the fungus. Then on the top you have polyenes, amphotericin B products against ergosterol in the cell membrane. Then you have triazoles, the main triazoles being Vori and Posa. You also have fluconazole, this is against ergosterol in the cell membrane as well. And then in the center you have pyrimidine analogs, this is mainly your flucytosine against nucleic acid synthesis. Like for cryptococcal meningitis, we often use ampho plus flucytosine, especially in the beginning, to kind of use, again, going after two different sites of action. So, next one, timeline for infections. This one is cool because these are actually things that are also clinically pertinent when patients ask you, like, why do you wait for the neutrophils? Well, one could say per this graphic that the neutrophils, thankfully, is the first cell line that re-engrafts after infusion. If one waited until CD4 count came back up, well, you'll be having your patients in the hospital for months on end, and we know that neutropenia by far is a very good benchmark on safety for being back out in the community, not having to wear a mask, that type of thing. Next thing is understanding when do the neutrophils come back. And one time someone asked me, he's like, well, you're only ID. Why do you care when the neutrophils come back? I'm like, well, because for us, the infectious risk is directly correlated with how long are you neutropenic. When you hit that critical 14 days, your risk for mold or invasive fungal infections goes up drastically. So, for example, if GCSF mobilized peripheral blood stem cell transplant takes 2 weeks to engraft, well, that's not so bad. But if you have a marrow graft, because maybe it's for an aplastic, it's going to be longer neutropenia. For us, we tend to be like, okay, well, if they're only being covered for candida with like micafungin or fluconazole, at 2 weeks we're going to ask for an updated CT of the chest to make sure we're not missing something in the patient who's been neutropenic for more than 14 days. With umbilical cord blood, definitely 4 weeks is not unusual. With certain chemotherapies, it can be even longer. And this is just also on the right side saying, first thing to come up, neutrophils, monocytes, NK cells. In theory, the last to come is platelets, but let me tell you, the patients definitely don't read the textbooks, and sometimes the platelets come up also very fast. I love this graphic, hands down, for anyone who works with me. This is from the Tomlin paper in 2009. It breaks it down, your 0 to 15 to 45. This is all about mucositis. I got chemo. My mouth is melting. My GI tract is melting. Then from day 15 to 45 to day 100, this is post-engraftment, acute GVHD, day 100 onwards, more the chronic GVHD, but you having some impaired cellular and humoral immunity, especially if you're still on immunosuppression or got one of the monoclonals. In terms of the different sectors, you can see the bacterial stuff in the beginning is all about the mucositis, viral, herpes. It's a stress response. Some of our patients come in literally admitted for transplant and they already have a HSV related ulceration, so we're very aggressive with starting our acyclovir. Respiratory infections are always a risk because there are no patients without nurses, and no nurses, there are doctors, and we sometimes come to work and we don't realize we're sick until we get home and we're sneezing, and we could have possibly exposed everybody at work. And then looking at the fungal section, Candida, the risk for Candida translocation related to, again, GI toxicity. Aspergillus, there are very specific indications stating increased risk for Aspergillus. You had it before when you were neutropenic. We're going to make you neutropenic again, so you're at risk again. Or someone is neutropenic for more than 14 days, items like that. Pneumocystis, it doesn't occur right away, but this is why, for example, in my program, you don't start pneumocystis prophylaxis till day 28. This is just talking about here. This dictates very nicely the prophylaxis that we utilize. This is talking again about the respiratory infection risk. So tools for workup. This is a moving target because the lab technology is changing. So The gold standard is still blood culture. If you're concerned for disseminated fungal infection, fungal blood culture, AFB, definitely if you think there's an infection in the bone marrow, you can also culture that directly. This is just to remind people, common positive infections, bacilli, cocci. More for reference, this is also common gram-negative organisms. Some of them require special growth, special media to make it grow better. So, that was more the old-fashioned. Let's talk about the quote-unquote newer fashion. Rapid diagnostics. When you go to the meetings, this is what it's all about. This isn't just an example using the BioFire platform. They have a blood culture identification panel, 27 things they're looking for, respiratory panel, GI panel, there's now a meningitis panel, there's an Ebola panel. So the FilmArray, how does it work? They have this little pouch. This does not take a master's degree to do. You inject a hydration solution, you inject a sample, add to a very expensive machine called the FilmArray, and then you hit start. And then it does 2 different PCR combos. And then with 2 minutes of hands-on time, you don't have to precisely measure anything, and in about an hour, you literally will most likely have the name of the bug that came from a positive blood culture. So for example, you get a blood culture, you send it to the micro lab. It's being constantly agitated in their big machine for 5 days traditionally. When it becomes positive, it'll make a dinging noise. They pull it out, they do a gram stain, they immediately release that gram-positive cocci. Then they do this at the same time with the BioFire. And then it'll say, for example, Staph aureus, and then you go to the far right and it'll say MEC-A resistant. So then we interpret that as, well, that's defining MRSA. So then you kind of move your therapy towards MRSA, for example. Unfortunately, currently for us, there's a gap because there's no strep viridans. So then it'll say, not this strep, not strep A galactiae, not strep pyogenes, not strep pneumoniae. So for those of us in transplant, that would be like, well, my patient has mucositis, looks sick as stink. Maybe this is strep viridans, and then there could be a whole bunch of different problems thereafter. This main slide is like the last comment. Results were reproducible. Whenever you bring a new test to the table, you want it to work consistently and appropriately. This is just about respiratory infections. We don't call it respiratory viral panel anymore because it does have 3 different bacteria: pertussis, chlamydia, chlamydiophila pneumoniae, and mycoplasma. And then this is a GI PCR panel. So note though, there's still no CMV on this, and that you could, for example, be positive for astrovirus, and then you say to yourself, well, what does this mean? It means your patient is now in isolation, but you don't have a treatment for the astrovirus. What's the problem with PCR panels? Now, it's, yes, easier to do, but there's no sensitivity data. All it says is, yes, I am here. It doesn't say what drug I should use. It doesn't say what drug I shouldn't use. It still takes another 48 hours on average to get a nice isolated pure colony to then run through the Vitek machine, and that is what will give you the full sensitivity panel about your bug. Talking also about rapid diagnostics, I have to mention them all the top. Much more commonly used, say, in super big programs, reference labs, or in Europe. Again, the same problem. It just says, yes, I'm here, but there's no culture data, so there's no sensitivity data. We do use a lot of the rapid diagnostics for urine antigen. Legionella and strep pneumoniae are my favorite. Legionella, though, you have to be smarter than the test. It only measures 1 serotype. That's only 80% of your Legionella cases. Therefore, 20% of your cases you will miss, so you have to be smarter than the test. This is where if it looks like a duck, walks like a duck, quacks like a duck, please treat it as a duck. If it's a nice lobar pneumonia for a person who came from the community with some kind of, soft electrolyte changes, then maybe the patient needs a bronch. Maybe you need to treat for Legionella. Well, strep pneumoniae is note, of course, that it is the etiology of 40% of your CAP cases, and we just had one on bone marrow transplant literally last week. Histoplasmosis urine antigen, I like this because it's a quantitative urine antigen that if you find someone has disseminated histo, and you're treating them, then it will slowly go down, ideally. Other tools are, single pathogen PCR assays, for example, like the HSV PCR. You see there's a lot of different things. It's rapid, it is cost effective, and very sensitive and specific. So, we finished tools. What about how to treat neutropenic fever? This is my bread and butter. Someone was complaining, they're like, where's the newest guidelines? I'm like, I don't own the guidelines. These are the newest guidelines, and this is what we work with. So fever, remembering that if it's a single temperature, 101 or higher, or sustained over an hour, more than 100.4. And our nurses are very good on our floor. They won't even call us until they've met this definition. They won't call us with the first low-grade fever. They'll wait for the hour, then it's elevated still, they'll call us then. The neutropenia is defined as currently or within 24 hours and ANC less than 500. This is just to remind us that when we talk about grading of data, this is a grading scale that IDSA traditionally uses. And then also kind of reminding ourselves, why are we even talking about infectious risk? And that these patients have had repeated cycles of chemo traditionally. They have disease of the bone marrow leading to neutropenia. Some of them might have low immunoglobulin levels leading already to increased rate for encapsulated organisms. That whereas solid tumors only have 10 to 50% risk for neutropenic fever, heme patients are definitely more than 80% of the patients, and unfortunately only 30% of our febrile patients actually have a documented infection. Doesn't mean it's not there, it just means we can't prove it. So, how do you risk stratify? When you see the patient each and every time, you have to look at them. Oral or IV antibiotics. Do I do it outpatient, inpatient? How long? Are they low risk or high risk? How do you describe low risk? Neutropenia less than 7 days. So this is more like a breast cancer type of patient. No or a few comorbidities that you can actually take oral antibiotics. You don't have mucositis. High risk, which is mostly all of our bone marrow transplant patients. Profound neutropenia, that you might have some comorbidities and more likely to have a cause for admission. Labs, definitely. A3 indication. Make sure you have some baseline labs. Make sure you have blood cultures from each lumen of the catheter and one peripheral. So for example, we have a triple lumen Hickman in all of our allos, so they'll get 4 sets of blood cultures. If someone has symptoms, then you do cultures, like if they have dysuria, you do a UA urine culture. If they're coughing up goobers, do a sputum culture. Chest x-ray, truly with respiratory symptoms, unfortunately, oftentimes there are a lot of facilities, they just say chest x-ray with neutropenic fever. Talk about bugs. Way back when, called the 1960s and the 1980s, our original problem was all about Pseudomonas. But then unfortunately things kind of changed in the 1980s and we started having a lot more gram-positives. You could be like, why did this happen? Well, a lot of things changed in that time period, and it was about the more aggressive, invasive type of chemo that you would have more mucositis, longer neutropenia. We were using more aggressive use of indwelling catheters, H2 antagonists, and of course, antibiotic pressure. So what about 2010s onwards? And for that, honestly, we just have everything plus resistance. This is just reminding us the common pathogens that can occur. There's a variety of gram-positives and gram-negatives from the gut. Pseudomonas is definitely there. The steno, depending on the type of flora you have in your hospital system. So, what about treatment? Coverage needed for Pseudomonas. We had talked about before my 3 favorite drugs. Anti-Pseudomonal cephalosporin, for a lot of places that's cefepime. piptasal, anti-pseudomonal carbapenem from a lot of places. Again, that's meropenem. If you have hypotension, pneumonia, or drug resistance, there's a variety of different other drugs you can use to kind of augment this regimen. IV vancomycin is no longer recommended as part of the standard initial workup for neutropenic fever. This is an A1 indication unless there's something you can see on physical exam, because, physical exam still counts in our patient population. Cellulitis or catheter-related infection is usually the main reason for this. There are special caveats stating that, for example, consider early use of IV vanc linezolid adapto to patients MRSA colonized for VRE linezolid or adapto. These are B3 indications. So, for example, what my group we discussed and kind of integrated was 48 hours. So the best part of your blood cultures, which are held for 5 days, is in the first 48 hours. So if you're MRSA colonized, you have a fever, we'll give you vanc with your, for example, cefepime. And if your blood cultures are negative at 48 hours, we'll stop the vanco. If you're VRE colonized, we'll give you dapto for 48 hours and then we'll stop it. The issue, of course, becomes these very random patients who never have screened positive for either, and then with their first bacteremia, they now have MRSA in the blood. But there's no way to stratify those patients because you already did the nose swab and it was negative, for example. Also, for ESBL, we are very aggressive. We'll say, if you're going to have neutropenic fever, you're going to get meropenem, and sometimes we will often de-escalate them back to, for example, Zosyn. If we go up to meropenem for the first couple days, nothing's growing, we might be like, well, we can kind of tone it down to Zosyn and finish our 5 days, for example, empiric coverage for neutropenic fever. If you're allergic to penicillin, oftentimes, if the story is, I had a rash as an infant, maybe after a viral infection, someone gave me amoxicillin, the likelihood is either they aged out of that, or that was more, the rash was from the viral infection exanthem. So those ones were we will easily re-expose to cefepime and even Zosyn. If someone has a history of anaphylaxis, then we're like, okay, you're going to get a monobactam ring. The problem with monobactam rings being aztreonam or ceftazidime, they're relatively narrow for gram-negative coverage, so you need some IV vanc to round it out so you get enough strep coverage for the mouth and the mucositis that will occur. If the workup is negative for this and the patient's on added gram-positive coverage, we'll DC it. If they're unstable, though, on the flip side, by all means, you're going to have to continue to escalate coverage and do workup to figure out why is your patient doing worse instead of doing better on their therapy. So, what about prophylaxis against Candida? The main thing is against invasive candidal infections. If you're getting chemo, you're going to be neutropenic. You have multiple different options here. But what about prophy versus aspergillus? And there were 3 different phrases. There's an A3 indication if you're neutropenic with a prior history of invasive aspergillus. Got it once, got it again. If you're anticipating that more than 2 weeks, or you're already neutropenic prior to transplant. So oftentimes these patients, for us, we use, for example, voriconazole as our first-line therapy versus aspergillus. So, what about some common issues? We have bacterial issues, viral issues, and fungal issues, but we'll keep this rather brief. So, one of the more dangerous issues in our patient population is Viridans group streptococci. It comes in many flavors, as you can see there. And it comes from the oropharynx. Traditionally, for us, this is translocation while neutropenic, and you have mucositis. Though the last couple cases I had, there's actually no mucositis in the mouth. It was all about the esophagus, so it can be tricky. Most of these present with fever and bacteremia. For us, we empirically start vancomycin because our flora at my facility, we have plenty of strep viridans, that is levofloxacin resistant. ceftriaxone intermediate or resistant, and so that's why we always add the vancomycin until we have in hand for sure what the sensitivities are. This is the bigger problem, that 10% have this toxic shock-like syndrome with ARDS, and the mortality can be up to 30%. This is one of the few times that the bone marrow transplant group that I work with will allow us to start steroids before engraftment to try to decrease the risk for ARDS. Understanding if your patient gets so sick that they're in septic shock, for example, they won't engraft anyways, and then the patient will ultimately have a poor outcome. So in the same idea that these 10% with shock-like syndromes and ARDS, there's increasing risk for resistance, like I mentioned. You first look at the levofloxacin sensitivity, then ceftriaxone sensitivity. You can see the risk factors there is the chemo and the H2 blocker use. Changing gears a little bit, for strep pneumoniae, this is now, once you're outpatient, that the invasive pneumococcal infection rate, that if you actually have chronic GVHD or graft versus host disease, your rate is 20.8 per 1,000, whereas if you don't have chronic GVHD and you're not on that immunosuppression, then it's much lower at 8.23. We give vaccination, but this is one of the few times that you'll see there's actually an indication for oral penicillin prophylaxis if the patient has chronic GVHD or low IgG levels. A different sector is enteric gram-negative organisms. Understand that this is usually the combination of neutropenia plus mucositis. I often tell the story of the one time I saw someone translocate 3 organisms at one time. Was not just neutropenia and enterotyphlitis. He also had C. diff, and then he had 2 gram-negative rods in his blood and 1 gram positive in his blood. But that was impressive because, again, he had 2 hits to his GI tract, the mucositis and the C. diff, and bloop, a triple bacteremia. But with targeted therapy, especially for gram-negatives, the duration is traditionally 10 days, and you're often able to salvage the tunnel catheter. Whereas, looking at this differently, if the patient translocated Candida, personally, I'd be like, get rid of the catheter. It's the likelihood that it's got a biofilm becomes very high, and it's very hard to salvage the catheter. Talk about viral issues. There's all sorts of different human herpes viruses, as you know. Let's talk a little bit about CMV. It's a beta herpes virus, double-stranded DNA, latent virus, a lipid-containing envelope derived from the host cell. The key thing from this slide is just to remember also it's the most common cause of TORCH, congenital infections in the U.S., that you can have shedding post-infection that lives on fomites, transmitted from person to person. This is just a neat graphic talking about the viral capsid. This is always what we look for when we do a biopsy. We ask, are there owl's eyes? Understand that this is congenital CMV rash, that it presents as a mononucleosis-like infection, just like acute HIV for that fact. My favorite, ketchup and mustard type of graphic, and that this is an ulceration that theoretically is CMV related. Diagnostic testing, most places are now using international units, though you have to be savvy about what your particular facility is using. There are some that, at least older papers, you'll see they talk about antigen PP65. This is an awesome lecture from Dr. Whitley that he was comparing and contrasting CMV and immunosuppressed populations. And this is always the issue between these 3 different patient populations. They have the same infections, but they have different rates and different presentations. That, for example, in a bone marrow transplant patient, we have the pneumonitis issues, whereas organ transplant and AIDS patients, not traditionally. So for us, for example, CMV negative, you should be having leukoreducing CMV negative blood. Definitely for us, our protocols, we check a Q Monday CMV PCR. Everyone has still slightly different cutoffs that dictate if treatment is needed. As I mentioned before when we talked about the drugs, there are pros and cons to them. Traditionally, induction is a minimum of 2 weeks. You ideally want to have your viral load undetectable prior to considering DCing your drug as well. Resistance issues, there are known risk factors. The first one's actually become a little bit more controversial, is which one is higher risk. But definitely the chronic GVHD, ongoing steroid use, low CD4 count, the use of these special types of transplants will have a higher rate of late CMV disease. This was from the AST/ID supplement in 2009, talking about the pathway for trying to treat someone with resistance issues in CMV. If you have non-severe CMV disease, there's the megadosing gang cycler, which I've done with Neutropen supplementation, or the half-dose versus the severe CMV disease where you go to foscarnet full dose. Talk about resistance issues, UL97, UL54. As you can tell with UL97, usually low level resistance. You can try to overwhelm the system with high dose ganciclovir or the utilization of foscarnet or cidofovir. For UL54, this is less common, thankfully, and very hard to extrapolate. For our lab, we actually use more like a phenotypic type of resistance panel. It just comes by saying sensitive or resistant. A few words about HSV. Traditionally, acyclic prophylaxis, where we just say everyone gets 1 year. But to be technical, the guidelines say if you're only HSV positive, it's 1 month. If you're VZV positive, you need 1 year. A couple words about VZV. Primary infection for VZV is chickenpox. Secondary infection is shingles. Now, isolation is only for, well, if you just have normal shingles, one dermatome, just, cover that area. But if you have chickenpox or disseminated shingles, 2 or more dermatomes, this is airborne precautions, negative pressure room. So my entire floor for bone marrow transplant is positive pressure. So these patients actually go to another floor for us to take care of them. At our facility, we use the acyclic 800 milligrams POBID, minimum 1 year for both auto and allos. If the patient is on immunosuppression, that definitely can be prolonged in its use. A few words about BK. I always think it's a cool piece of medical history that BK was the initials of the original patient that they found this in. Urinary shedding in immunocompetent blood donors is between 5 and 20%. That the patient populations that traditionally have problems are kidney recipients and bone marrow transplant recipients. Understand that the same infection in kidney transplants presents as silent loss of the graft, whereas in bone marrow transplant we have the whole hemorrhagic cystitis issue. In bone marrow transplant, how does it work? Is that you lose your CMI, cell-mediated immunity, versus BK. You get increased replication in the urine, and then it replicates in the blood. So we have shedding quite a bit in our patient population, and that our rate of hemorrhagic cystitis as all comers is about up to 15%, 3 to 6 weeks post-transplant. Again, this should not happen right away. If something happens right away, it's not because of the BK, it's because of other problems, which we'll talk about in a moment. How do you treat it? The best way is to decrease immunosuppression. Otherwise, there are complicated algorithms looking at the use of cidofovir and other drugs. From a different perspective, if you're looking at a patient who has hemorrhagic cystitis and you're like, what is statistically causing this problem? You could be like, well, is it related to something I gave the patient? Chemo. So then you should realize cyclophosphamide, this is why we give them mesna, ifosfamide, more for solid tumors, busulfan, which we definitely use in bone marrow transplant, and TBI, also used in bone marrow transplant, versus pathogens. Is it just a UTI? Is it adeno? Is it BK? We one time had a case, for example, that had delayed diagnosis because they did the BK but not the adeno. Thankfully, the patient survived. Physiological problems. Does the patient have ATN or low platelets? Fungal issues. Moving towards the end of the lecture. So invasive fungal infections in stem cell transplant, number 1 is definitely Candida, Aspergillus, Mucor, and Fusarium in decreasing rates. So talk about Aspergillus drug of choice, Vori, Amphil products. Now with the use of Cresemba, that's also on the list. Overall, you decrease immunosuppression if possible when you're trying to fight an infection like this. Mucormycosis is the third common invasive fungal infection. Honestly, surgery and Amphil, there is data for POSA and isoverconazonium. Again, we try to decrease immunosuppression if possible. Fusarium, this is why we're so clear about you're not allowed to clip your nails while you're in the hospital. Don't go ripping your nails, nothing like that. Amphil, Vori, POSA, debride if needed, decrease immunosuppression if possible. I like this graphic. I mean, I made it, but to help me compare and contrast what I needed to remember, like prolonged QTC, don't use Vori and POSA. Short QTC, don't use isoverconazonium. Hallucinations, you ordered a Vori, you better be counseling the patient on 30% chance of visual alterations is technically what I tell them. They usually then look at me and you're like, are you telling me I'm going to hallucinate? I'm like, well, the lights can get bright and then they go back down. That's normal. If you start seeing bunnies across the floor, no longer normal. Nephrotoxicity for all formulations, Amphil. Nephrotoxicity IV only, this is for Vori. This is important because if our patient, for example, is on Cipro, Vori, and acyclovir and they have mucositis, I try to, on the first day when they're still feeling well, warn them that I really only want one of the Vori or acyclovir to be IV because you don't want both drugs to be IV because that's double trouble for nephrotoxicity but different mechanisms. Drug level monitoring recommended. We do that for Vori after 5 to 7 days. Drug-drug interactions. All of the azole-related drugs have drug-drug interactions with our immunosuppressions. Photosensitivity rash. This is always my favorite because my patient went fishing when he had voriconazole in his system and came back looking somewhat like a purple smurf. And it was definitely in a exposed area. It took a very long time to resolve, so definitely photosensitive. Transaminitis, all of the azoles, and fluoride accumulation, originally described in the pediatric sector, but we definitely have seen it here at our system, especially when the voriconazole is more than 3 months. Just a word about resistance, that Candida resistance is 3 to 6% for fluke and Vori. Candida glabrata, look how fast it has increased. Aspergillus fumigatus up to 6%. At my facility, we even have found multi-drug resistant fusarium. So, a few words about ID resources and then we'll finish up. Remember that there are the free guidelines that are on the infectious disease site that you should be utilizing in your studies. There are also the ASCO, kind of like the HEMONC perspective. My favorite is the Sanford guide, used especially because of the tools and tables. Then there are the NCCN guidelines that also are updated. Lexicom is also a very good resource for especially the pharmacy perspective. And then you're already listening to the ID podcast, but of course the fact that there are many other lectures available to kind of stay up to date with what we think is pertinent for today. So, conclusions are treat each patient as an individual. I think sometimes we get into this idea of like, well, they're all neutropenic fever, I'm going to treat them all the same. I'm like, not quite, because they've had different chemotherapies that get to you. They've had different infections prior. Maybe this person on the right had UTIs, but this one on the left did not. Where on the continuum of transplant is he or she? You know, how neutropenic, for how long, risk factors and exposures, sick contacts, drug-drug interactions, chemotherapy interactions with our drugs. So, going back to those questions we had, when is a stem cell transplant patient at risk for community-acquired infections? It's D, it's all the time, because they're exposed to other people all the time. What is the empiric drug of choice for neutropenic fever in a patient who has a history of ESBL in the previous chemotherapy regimen? This one would be meropenem, because the other ones, the ESBL would eat up those other drugs, and then that would not be good. I say that facetiously, of course. Which anti-mole therapy is contraindicated with short QTC syndrome? The idea here is isoveroconazonium, also known as Cresemba. These are my references, and I just like to, of course, as always, say thank you to all our patients and staff, the SMART team, which is our stewardship group. I wouldn't be able to do this without all of them working with us. And this is our group. We actually have more people now, and I need to update this picture, but soon, for next time. Thank you.